Yes, good morning. Had to check my watch and make sure it was still morning. Well, first of all, thank you so much. I'm so glad we're having this time where we can actually really talk about these topics that are critical toward addressing the needs in our communities. And as Judy said, thank you for that introduction. It is a pleasure to be here, and it is certainly a great opportunity to think about a different lens, if you will, from what we've been talking about here. I think Dr. Petit actually hit some of the points I'm about to talk about, specifically around community engagement. Um, I am a medical sociologist, and so I would be remiss as a medical sociologist to not make sure that I talk about how important it is for us to think about how our communities are actually engaging with the healthcare system in ways that are challenging, difficult to navigate without question. And also, I think it's important to make sure that throughout that process and the research and the work that we do, that we make sure that we have that patient and that community perspective front and center. And that also includes how it drives policy and how policy is informed by research and ultimately by our stakeholders, by the populations in our communities who are least advantaged in these areas in accessing care. So I decided to give myself my own personal assignment as I spoke with Kate about this talk and spoke with Dale and Judy as well. I was pretty excited because I should have found out how to use this, and I'm hoping it's going to be straightforward, and it is good. Whew. Okay, next. Absolutely, vulnerability is a good thing. Um, so one of the things that I noticed through this whole process, and it gave me an opportunity to really start thinking about what does that voice always look like. And when we talk about race disparities and other types of disparities, it's always important in this case too to ensure that we have the voices of our populations at the front and foremost. And so, anytime I'm giving any type of talk or presentation or anything along those lines, I always try to find some kind of quote that speaks to who we're talking about in the room and what we're trying to move forward. And so in this case, I asked two people actually, and of course my research, I have plenty of research that can actually show this too from some qualitative data that I did with a project that I had that was NIH funded called Project Place, population level approaches to cancer elimination. And it allowed us to actually ask some specific questions around sexual and gender minorities, specific around their view and perspectives around medical research. And most certainly without question that the data with 2,315 respondents, it was quite clear that sex and gender minorities do not trust research. They don't feel safe in it. And also, likewise, they don't feel safe in the healthcare system at the same time. And that's no surprise, I'm sure, to anyone. But whenever we have data like that, sometimes we can, as researchers, get so caught up on the big numbers and forget the people. And so my goal today is to bring us back to the people. So that being said, I asked a couple of friends and colleagues, what are their views and perspectives as it relates to policies that impact their day-to-day interaction in the healthcare system? This is one of the quotes. The first one I didn't put up here because she said, wait, there's policies to protect me, which says a lot, a whole lot right there. That means that our patients and our community members who are actually even coming into the health system do not even know or aware that there are policies already in place to protect them to some extent. That speaks to the next phase, which I'll talk about in this side. So here we have one of my friends who's been friends now for over 20 years. And again, this just illustrates data, so it's not like my own N of one. So let's be clear about that too. But most certainly here, she highlighted, my child is on Medicaid, and my girlfriend and I, we seek care for him all the time. If it is clear to me that we are treated differently, people are uncomfortable, and I see staff and others look at us as we seek care as a lesbian couple. Add on the fact that he is on Medicaid makes it even worse. Policies can only protect me, my wife, and our sons to an extent. But people who work within the organization makes a difference and can impact our trust and comfort in seeking care as lesbians and parents. It was really powerful because here this really spoke to, we have a lot of policies, well, we not a lot, we have policies that need to be reinforced, certainly policies, as we just heard about now, that are actually being repealed in many ways. When we think about our organizational policies, there's a little bit more control, if you will, that organizations can have in how they practice care, how they practice an inclusive environment. And so in this context, for certain, this is an area where we're talking about this person engaging specifically in a healthcare system. So what we learned through this, and for me as a stakeholder engagement and stakeholder strategist, community engagement strategist, there are a few things that I think is really important. How do we, and I think the example that Dr. Prateep highlighted earlier about going into the community with a trusted partner and learning from the community what's important and then evoking change from that space, which I think is so critical. So my first point when we think about aligning policies is that oftentimes we have policies, we have mission statements across organizations that say we are diverse, we're committed to diversity, every patient that comes in our system is most certainly going to get the best optimal care. But clearly the data shows differently. And so my question is, how do we make sure that the research and the work that we're doing truly aligns with the diversity statements and mission statements of our organizations so that when we see the policies that's happening at the organizational level, how well does it align with the care that that patient is experiencing on that day when they come to get the care? Just in the case of this and many others, Dana and I talked about this in many ways, where people may come into an organization and we have employees, right? So an organization made up of people, they're made up of organizations and staff. They're also made up of researchers and clinicians. And so how do we make sure that those groups are truly abiding and following through with the values of the organization, not of their own personal experiences? And so what can sometimes happen is when organizations present these policies, it automatically creates a us versus them. Which in and of itself, I think the other point was made where it becomes like this off conversation. So this is the norm, and then we're going to do this here, specifically for SOGI populations. That's a problem just in the language and the way that we communicate that as organizations. So again, this is how a policy that can happen at the national or federal level or the organizational level can actually translate locally in a way that still becomes very oppressive, not engaging, not open to our populations. And so what I say, and I encourage us to think about for research, is how do we make sure that our patients and all those stakeholders are at the table at every juncture? So could it be possible that we start looking at research in such a way that when we see a policy that comes into play at the institution level or national that needs to be implemented locally, how often do we engage our communities in which those policies are going to affect, to ask them first and foremost, this is what's coming down the pipeline. This is what it looks like in terms of HB2. This is where we're going. What does it mean for you in terms of your day-to-day experience as you engage with our system and our organization? That's the types of ways in which we can become more proactive and engage our entire institution around policies that are coming down the pipeline instead of those who are making those decisions make the decisions and tell everyone to operationalize it without a true understanding of the people and understanding and engaging the people at that space. So that's one point that I think is important. I think we also then miss out the nuances. So a patient can come into our healthcare system, check in at the front desk, and I'm not saying this specifically to Duke, this is just about any health system that you could think about across the country, but they can come into the healthcare system, check in at the front desk for their appointment. As they come in, they check in for that appointment, the person's already looking at them kind of in a way that's like, and starting to question. No matter what someone says, you can pick up on the nuances associated with what people are really thinking. What are we doing as an organization, as organizations, to ensure that we're providing the appropriate training, the appropriate education, and the appropriate awareness for the stakeholders that are in the system to ensure that those things are happening in a meaningful way? We've heard about implicit bias, and I do a lot of training in that space. I've developed a couple of trainings actually now that are both community-based and facing and system interventions to specifically start thinking about how do we ensure that people are providing the type of care that our mission statements actually state, as opposed to assuming that because you're a staff member, because you're employed, and you get a paycheck by a particular organization, that all of a sudden you're going to, for the most part, follow those policies if it's just stated that this is now a new policy. So again, stakeholder engagement is a key part. The other part I think is important is that it would be really important for us to start thinking more creatively about how do we look at those mission statements and align them with what's actually happening from an accountability standpoint. And so when we think about the enactment of policies and those statements that are made around diversity, around inclusiveness, around ensuring that every patient gets the optimal care, what does that really look like? What are the appropriate metrics from a policy standpoint that allows us to know that we are moving the needle as an institution in that direction? Oftentimes, again, from a policy standpoint and from a stakeholder standpoint, that's where we can get some of those that information from. So how can we create that innovation? Again, engaging our patients, our community members in a way that allows us to understand what those metrics should be. We oftentimes use metrics that are very broad and don't allow us to get into the nuances that actually could be part of making those changes as well. So again, that's another piece to that. As a sociologist, I also want to identify another area, and that is looking at the social cultural norms, which were already addressed to some extent when we think about the South. We're in the South, without a question. We are considered the part of the Bible Belt, without question. Does that, and that oftentimes characterizes where we are from a region standpoint. It doesn't characterize, or it doesn't have to, I should say, characterize the organizations who's providing care. We allow it to, but it doesn't have to, right? And so just because that's what it is in the region, what do we as institutions do toward making the appropriate policies, the appropriate programming, but also the appropriate engagement that allows us to better understand what that policy looks like for us, even though we're situated in the Bible Belt? How do we as an institution start aligning what we expect our staff to do to ensure that every patient that comes through that door gets the optimal care and services that they deserve, as anyone should, regardless of what one's individual vision or value or perspective is. So I'm asking us to start thinking about our communication, thinking about our language, thinking about our metrics, and thinking about, most of all, our engagement. How are we engaging our diverse stakeholders? How are we engaging our community partners in such a way that can move us to a space where we become more proactive? So when we hear about the policies that's coming into place, do we have a network of people in our community who are already ready, armed, and advocate to be able to highlight and even give the voice behind the policies in which we are talking about, which is huge. And then the last one, again, deepening our examination of our local national policy and how it's practiced. How often do we see, one of my friends and colleagues talked about how when they walk into the health system, they actually come in, they get the care, but they can see and different staff members, someone who could be simply on the side, who could be cleaning, for example, looking and giving a look that automatically makes them, their family members feel like, oh, I'm not welcomed here. So again, how do we stop moving our organizations, and how do our organizations and start moving from a space of simply saying we have a policy toward actually moving us to practice? What does that look like at practice? What does that look like at the ground level? What does that look like for our patients? And most importantly, what does it look like for our staff and our teams and our clinicians and our researchers, our front desk staff, everyone who is a part of the we organization? How do we ensure that they are getting the appropriate training and the appropriate messaging and communication from the organization to ensure that they clearly understand that there is a difference between your values and the values of our organization? And if you work here, your goal is to follow the values of the organization despite your personal views and perspectives. So that being said, I think it's really important, again, for the research that we're doing to move into that direction. I've learned a lot from the research I've done with Project Place. I continue to do the work that we're building with the implicit bias training that I've done with community partners, and now that alone showed a huge difference in how staff can actually perceive their own values and the values of the organization. What's really interesting is that the more they become aware of the depth of the values of the organization, we actually saw a shift in how the staff started to think about their own values and how they perceive patients who are sexual and gender minorities. So there's hope there. I think that the challenge is that large institutions have a power and ability to make shift and make a change, but it requires accountability, it requires the appropriate accountability, and it requires inconsistent community and stakeholder engagement. Thank you.